As you finish up your thought, you have made it to the 7th and final pitch. So congratulations. Dr. Paul Glassman, who you've met already, he will be pitching building awareness about community-based dental disease prevention and early intervention treatment programs. We saved the longest one for the last. Welcome. Thank you.
So almost at the end. So, one of the things thinking about the format like this was an experiment. We weren't really sure how this was going to work. It was very different than the way the planning group was originally thinking about doing this. So how many of you are feeling energized? All right. I was thinking about what you said, Tuke, about the difference between polygamy and monogamy. And polygamy takes a lot more energy, really. Monogamy is a lot simpler, really. And of course, when you have this kind of format, the extroverts love it. More conversations, more people. I can't. And the introverts are going to have to go take a nap for about 3 weeks afterwards to recover from all of this. But I am actually glad to hear that most of you raised your hand when you said you're being energized. And of course, that was the idea, to raise the energy level and raise the awareness. So last pitch, I'm going to talk about this thing, which you won't have any idea what I'm going to talk about by looking at the title, but I'll try and explain it to you in the next couple of minutes. You'll see it has a lot of overlap with a lot of the presentations that have already taken place. And maybe it's fitting that it's at the end. I felt like I sort of drew the short straw, getting the last place when everybody was exhausted, but clearly you're not exhausted. So it was a benefit. So try and see if we can tie some of these things together. So one of the things I did in looking at this priority was to look through the oral health plan and see the things that had been addressed and not addressed. And this one, it's strategy 12G, which is in the previous 2-year plan. It says provide training and guidance to support development of evidence-based, community-based dental disease prevention and treatment programs. And I realized this is also something that's mentioned in a whole bunch of places in the state oral health plan. There's one about engaging and offering best approaches to support community health centers. There's one about changing home visiting programs. There's one about providing guidance in systems like the virtual dental home system, which you've heard mentioned a couple of times today. I'll come back to that in a minute. There's one about encouraging community health workers. There's one about increasing the number of FQHCs that provide dental services in community sites. Back to our opening presentation from Amanda. Thank you, Amanda. So there's clearly a lot of stuff in the state oral health plan about reaching into the community and engaging the community and doing things in the community. I've been thinking about this. I've been talking about this, and some of the work I've been doing over really the last couple of decades has led me to the idea, which I know Dr. Fine is a big fan of, the idea of what I've been calling this community engaged oral health systems. And when I think about in community engaged oral health systems, it's actually an idea that's pretty different than the way most people in the dental industry think about dental health. Most people think about dental health happening primarily in the dental office, the dental office being sort of the center of the dental universe. And to the extent that we reach out into the community, the reason we're reaching the community is to do some stuff, but really the end result is to get people into a dental office. So I'm going to propose to you that we have an opportunity to help the dental industry and all of our colleagues and anybody who cares about oral health, about Dr. Kumar's path towards having California have the state with the best oral health in the nation, that we have an opportunity to rethink this idea of what does it take to have good oral health. So I think the path is, I've developed, I don't have time to go into details, but there's several things that are pushing us in this direction. One is thinking about new delivery systems, incentive models, and then prevention and behavior science. So we have all this new stuff now in the dental care system. We have fluoride varnish and silver diamine fluoride. If you're not familiar, 1 drop of this liquid stops the progression of decay. We have sealants, which, I don't know if you know this, but when sealants were first invented and began to be used, the idea was you were sealing up these grooves in the teeth so you wouldn't start decay, but you would never put a sealant on a tooth where there was already some decay there. Well, now we know that's absolutely not true with our modern materials. You seal over the decay, it doesn't progress. You can go further with interim therapeutic restorations with dental hygienists, and expanded function and assistance in California can now place even with a small hole in a tooth. No drilling, no anesthetic. You scoop out some of the soft material, you seal it in place, and it doesn't progress. So the main thing about this is not a mini dentistry 101 lesson. The idea here is that these are all things that don't take a dentist, they don't take a dental drill, they don't take a dental office. These are all things that can be done by allied oral health personnel in a community setting. And in fact, I'll show you in a second, most people don't really need anything more than this stuff. So it opens up a whole new world of opportunities. I've been referring to this idea of a full service, community engaged oral health system where the dental office still has a role. You have a dentist who's able to, in a virtual dental home system, like many people are beginning to use, x-rays are taken in the community. The dentist can review the x-rays in the office, make a diagnosis, a treatment plan. People in the community can actually carry out many of the aspects of the treatment plan. We did actually a big, this is about a decade ago, a big 13 community 50 site demonstration of this idea. And we were able to demonstrate that we could reach people who were traditionally not getting dental care, that we could actually keep the majority of people healthy in the community. And with children particularly, that was 2/3 of children could be kept healthy in the community without having to make a trip to a dental office. And that was before silver diamine fluoride was available. Now we're estimating 85% of children could be kept healthy out of school. So think about that for a second. Take that Paul Lee deep breath. And digest the fact. Think about that. 2/3 of children kept healthy at school, with only a very few of them needing to make the trip to the dental office. The dentist has already done the examination through a virtual system, so they don't have to go to get their examination done. What a game changer that is in terms of the way we think about oral health. So I think what's been actually missing, to think about sort of centering our idea of oral health in back in our island community, back in the community, that this is the place where the action needs to be and the opportunity we have. And so my pitch to you is to support this idea of doing what we have to do to raise people's awareness. I think most people don't really understand this opportunity. Most people really don't have the background or the technical skills. So we need understanding, awareness, we need technical assistance and training. But I think it really knits together a lot of the stuff you've already heard today and the other priorities. And we have an opportunity to fundamentally change the way we think about oral health and actually be able to give Dr. Kumar his present and make California the healthiest oral health state in the nation. So thank you.